your average rheumatology patient. She is super, super articulate and an amazing advocate for herself. She also has a background as a practice manager, medical practice manager. So she, I can ask you some questions. Let me just, so these are some folks from Novartis, and they are launching a new IV formulation of the sub-Q drug. Okay. So, what they want to understand is the patient experience of a rheumatology patient and any kind of barriers that you've experienced, and you know you're not those barriers together. So, she was one of my very first patients that we drew a line in the sand, and it was with our friends at United Healthcare.
Yeah, and I just got a thing in the mail saying, oh, you're approved for another year, so.
Imagine that. They don't want to tangle with you.
Right.
Or me. Right. So she was my very first patient that we went to battle with United Healthcare. And after letters of medical necessity and peer-to-peers and appeals and all this nonsense, they kept saying no. So what did we do? We called up Channel 2, local yokel news here, and said, hey, Mike Colombo, news reporter, do you want to have Dr. Bach and Denise Brown and do a little interview so we could get United Healthcare to take care of the patient? And he said, sure. So we had him come out and he interviewed Denise and Dr. Bach. You can Google Dr. Steve Bach and Denise Brown on Fox 2, and you can see her interview because it's still there today. So tell them about that experience.
Well, first of all, I thank Julie for giving me the opportunity for this. It is so important that as a patient and as a practice manager, I see both ends of it. I always knew as a practice manager the hurdles and things that our patients had to go through, but until I was blessed with this particular diagnosis along with a host of other diagnoses, I never was really privy to exactly how our patients felt. And so I was diagnosed in 2015 with rheumatoid arthritis, ankylosing spondylitis, and adrenal insufficiency. I have a whole plethora of diagnoses. And Dr. Bach tried me on several different medications, IV, oral, injections, and so forth. The last medication that I was on, it didn't work, so they wanted to switch me over to another medication, and they said no. Thankfully, Julie, who is an advocate for her patients, was able to get that particular medicine approved, but then lo and behold, here we come, United Healthcare says, oh, you can't have this in the doctor's office or in an ancillary facility, you need to go to the hospital. Well, you guys know, you have no immune system. You know what it's like when your patient actually goes to the hospital for anything. Something that could take an hour has a patient there for 3-4 hours. I look at it as on the practice manager part, and I'm thinking, well, it's not cost effective. It is just not cost effective to have your patients go here. So Julie and I talked about it. I refused to go. She refused to send me. And so we went back and forth, back and forth. I think Julie even contacted Jeff City, also advocating for me and other patients. And when you put the pressure on, they start to respond. And so by me being the practice manager, I also knew the medical director for United Healthcare. So calling him up, sending emails, corresponding with him. Thankfully and blessedly, I've got it approved. My billing is a little bit different. I don't care though, it's approved. The thing about it is, and so we decided to do this interview with Mike Colombo because we needed to make just everyday patients aware of the hurdles that they go through. What we see is that we're numbers. We're numbers. And so when you call in, I know when you call in, all you're seeing, basically, you're getting a customer service rep with no medical experience. They're reading from a script. And you are just a black and white patient, but every case is different. And we don't see that with the insurance carriers. And unfortunately, a lot of times, our practice managers, our office managers, they just don't know how to fight or advocate for the patient. By me being in healthcare and having the background, of course I know the ins and outs, but our regular patient who is suffering with an illness, a chronic illness, which may or may not be under control, it's almost devastating. Even for me, who knew the ins and outs, Julie can tell you, I was upset, I was devastated. And I've been with this carrier maybe 15, 20 years, but I'm just a number on a piece of paper. And so we were able to do the interview. The interview was well, kind of shook up some things. And then the next thing I know, I'm able to have it inside the office, which is better for the patient. It's more comfortable. It's a more intimate setting. You're right there with your providers. If you have questions, they're there. And so that's how we came about with the interview.
Anybody have some questions for her?
What was the reason they were asking you to go to the hospital if they gave you a good enough reason?
You said, why were they asking us to go to the hospital?
Yes.
Well, a lot of times, of course, you know, they're contracted with the hospital. And they also are the gatekeepers, and they say that they are not the gatekeepers, but they do control our care. And it's all because it's cost effective. And so they think that it's cost effective. But when you take the average of how much the medication costs, how much it costs for the administration, time, how much you're paying your staff, all of the overhead, it is not cost effective. And where maybe one of the medications costs $20,000, they're probably gonna pay the hospital, I don't know, $2,000, $3,000 for it. But it's just not good for the patient. You have somebody here who is autoimmune compromised. You have all of these other patients who are autoimmune compromised. And then you have, just walking in the hospital, we're risking our health. But a lot of times the carriers, that's not important to them. They just see, you know, your number on a piece of paper. Yeah. Yes.
So Julie, over time, are you starting to see more and more of these site of care policies where they're requiring you to go to certain sites, like for a number of your patients, and how often do you have to push back?
Well, I push back 100% of the time. And the site of care usually works from the hospital to the infusion center. But they, like if it's a CVS PBM patient, they want you to go to the CVS location, which is in East Overshoe, okay, and not remotely convenient. There's no physician supervision. It's all done by RNs, and there's probably a PharmD on site there. No disrespect to PharmDs, but these are complex biologics that we're dealing with every single day. And when you come to my office, they're gonna do a site tour. My office is across from the helicopter landing pad at the emergency room. If we need the emergency room, we're there.
And when you have a patient like me who has several chronic diagnoses and illnesses, one of the pre-treats for the IV infusion that I get is steroids. Well, I have adrenal insufficiency, so my steroids have to be monitored. One day, in the morning, I may take 40 milligrams of steroids. The pre-treat for that particular IV infusion is 60 milligrams. So I've got to let my nurse know, hey, I've taken 40 milligrams already. My nurse doesn't have to get on the phone and wait to talk to the doctor. She pulls them out of the room and say, hey, am I giving her 20 milligrams now? Or she may say she's not feeling well. And they know your history, especially Julie's office. The providers are excellent. You say your name, they know exactly who you are. But he may say, well, no, we're not gonna give the treatment today because of this or that. They're able to inspect. Do you have any open wounds or anything like that? There's been a case where I've had an open wound on my leg. I didn't have to wait for a doc or a house doc to come down. I'm right there in the infusion center. They grab the doc and he says, okay, it looks like it's healing, it's okay. I've had aftercare for surgeries. Are your stitches still there? So it's so convenient for the patient to be able to get that care in sight. Yes.
First of all, thank you.
You're welcome.
Really powerful, because I think you're, as a patient, but also your medical knowledge. As a patient, I'm sure when you first were, I want to know about when you first thought about or were told about going on an infusion therapy. And I'm sure like there's an intellectual part of it, an emotional part of it. Can you guide us through how that looked?
Intellectually, I knew that it was necessary, and that's where my course of treatment was taking me. as a patient, first of all, you get this diagnosis of rheumatoid arthritis. I was in healthcare. I know patients that had rheumatoid arthritis, so you see sometimes the extreme cases. I knew for me, the way that I was feeling, that probably an oral med wasn't gonna work, but we did a course of oral meds. When I say a course of oral meds. I call it a cocktail. And then we did injections. And so when Dr. Box said, hey, I think it's time for you to get these IV treatments, as a patient, it was disappointing. And even now today, I've had so many, I've been getting the IV treatments, I think maybe 3-4 years, but every time I still go to get that treatment, I sit in that chair and I laugh, smile, I know the staff, but in the inside I'm saying, I am putting this poison in my body to survive. And you always still say, why me? Now, I am a person of faith and I know that God gives you things for a reason. And I've been able to advocate for myself and other patients, so I'm grateful for that. But at the same time, as just a regular patient, you know how you're gonna feel the next day or the day after. So it is really mentally taxing leading up to that time getting it. Probably, 2 or 3 days before I'm telling my husband, oh, I have to have my treatment, I have to have my treatment. That morning, you're shaky and you're thinking, oh, here I go. The minute that they put that IV in your arm and you start to feel a little warm and you feel all of the meds going in, your mind says, I have to do this to survive, to live a normal life. Why? Intellectually, I know it does me well. 2 or 3 days later, I'm back feeling okay, and then here you go again. Luckily, I'm on one of the treatments that I get it every 5 months, and even with that, or every 4.5 months. You get this treatment every 6 months is what I started, but it wasn't helping. And so when they say, well, we're gonna move you up to 4.5, 5 months, you're thinking, here I go again, what's working? What's long-term for me? Is this gonna stop working? So you think about all of those things. When you're getting that treatment, I'm thinking, okay, it's been working so far, is it gonna work? Because I've been on a course of treatments that haven't been working. So it's a little nervousness. But the place of service is so important, because in the office, you get to know the staff. You get to know the practice managers. We even get to know little Bunny. So they have Julie has a dog, it's Bunny, and she's really our service dog. And so it really helps having it in the office. They provide us with snacks, water, whatever it is. They are getting those things for us. And in a hospital setting or another ancillary setting, you don't get those type of things. So it's taxing intellectually, not intellectually, but emotionally as a patient. And I still get emotional even when I talk about it, because I think, here I am. You saw this with your patients. You can sympathize with your patients, but until you are in that situation, you really don't understand what empathy for the patients are.
Can I have a follow-up? And is there anything that you expect or would like to see from the drug companies?
I don't have a lot of interaction. Well, actually, I would like for the drug companies, for some type of way, be an advocate for the patient. Like I said, we're just a number on black and white. A lot of the drug companies, they have co-pay assistance programs and that type of things, which really offsets some of those for our patients. One of the things that I do see though is that sometimes the Medicare patients aren't eligible for that. And I would love to see the drug reps, the drug companies, do something to offset that for our Medicare patients. Some of our patients have Medicare, Medicaid, and it gets offset. But for our regular patients that just have Medicare and maybe a supplementary insurance, they're out of pocket. Sometimes I've been in the office and, I was there not too long ago and a gentleman was paying like $400 and something. And I'm thinking, you have got to be kidding me. He had Medicare primary. He had to pay $400. I pay a $40, well now $50 copay, and depending on where I am in treatment, I may have co-insurance, but it's nothing like $400. but these are older people that are on fixed income. So that's what I would like to see, is that somehow the drug companies can offset their costs with Medicare or advocate for some type of assistance for our Medicare patients.
Any other questions? I know Stephen Kiss has one.
I do have one.
Oh.
So Denise, obviously, you have a really strong understanding of the healthcare system, and you have a strong advocate with Dr. Bach's office and Julie and team, and it still was hard to get therapy. My wife works for an insurance company. She has RA, and she has trouble getting her medicine. I'm just curious if there's patients that don't have a Julie or a Dr. Bach, any ideas on who they could go to or how support could reach them to help with
Fortunately,
advocacy?
some of those patients, and I've met patients in Dr. Bach's office, and sometimes they're just ready to give up, and I tell them, don't give up, talk to Julie. But I do have a friend whose sister has RA as well, and she is a Medicaid patient. She doesn't have a Julie, she doesn't have a Dr. Bach. Fortunately for her, I've been able to help advocate for her. And the drug reps have worked some assistance out for her, but for a normal patient, they don't understand those ins and outs. For a normal patient, even for her, she was just like, well, I'm just gonna hurt. I'm just not gonna feel well. I don't know what to do. And I learned that just through passing conversations with her at the gym. But for a normal patient, they just say, I can't afford it. I can't afford this care, I can't afford this treatment. And we know that this can be a progressive disease. And so, she's 42 years old. She has a complex case. Had she not gotten treatment, she probably would be immobile or I don't know. But a lot of times, there is no Julie, there is no Dr. Bach. There is nobody like me who knows the ins and outs. They just don't get the care that they need. And it is so unfortunate, and it infuriates me because our carriers know this. They know that. You can call, you can write appeals, you can do whatever you want to, but you are just black and white on a piece of paper saying, no, you're too expensive to do this, so we're gonna give you this medicine that is not effective for you, but we're gonna treat you though, And so the side effects are outweighing the benefits of that medicine. But normal patients, the answer to your question, they just give up.
Denise, hi, thank you for coming and sharing your story.
Sure.
Are you involved in any patient support groups, or do you feel like there's a role for that, and how could we maybe?
I wish that there were patient support groups. I've tried to find patient support groups, but they're not very supportive. When you hear all of the negative things, and some of the patient support groups, they want to direct your care. And so they're not sponsored by a drug company or a physician's office or anything. So here you have somebody with experience who has a chronic illness like me, and they decide, well, let's do a peer group, let's do a support group. But they're telling you all the bad things. So they're telling you, don't take this IV med because of this. They're telling you, and I don't know how many times I've had this, oh, you've got to eat a plant-based diet. Oh, you have to go on an alkaline diet. And yes, those are some benefits, but I do that. But it's also important for me to take my medication. It's also important for me to have these IV infusions. So another thing that I would like to see is for some of the drug companies to actually sponsor some of these support groups where they can bring people in and professionals in and talk about some of these medications, or just a course of emotional support for the patients as well. But I find that a lot of the support groups are dangerous.
Just to follow up to that, what about like on social media? Do you look at social media for those same types of things like support groups or information groups?
Initially, when I was diagnosed, that's the first thing I did. I ran to Facebook, I ran to Instagram. I had to get off. Simply because you hear all of these horror stories. The first med I was on was methotrexate. It's the first course of treatment, oral methotrexate. I go on there, I Google methotrexate, or I look up methotrexate on Facebook, I join these groups, and all you hear are the horror stories of methotrexate. So you have a newly diagnosed patient, and you're hearing all of these horror stories. So what do they say? Oh, well, this patient had this problem, this, I'm not gonna do it. Well, we know that each patient reacts differently. And for me, I'm thinking in the back of my mind, okay, I know patients that's been on methotrexate, no adverse side effects or whatever. Okay, so if I'm nauseous for a couple days or flu-like symptoms, that may be just what I have to do, but normal people don't think about that. We're looking for a quick cure, we're looking for comfort. And so those are very dangerous too. And so a lot of times I'll tell, in the case of my friend's sister, I tell, get off of social media. Get off of social media, do not listen to it, because you expect to have all of these things. She, for one, was on methotrexate, and one of the side effects, if you're not taking folic acid or enough, you get mouth sores. She didn't have a mouth sore, but of course she started saying, my mouth is sore. I feel like I'm getting sores, because those are the things that social media, and some of these support groups, they plant in us, when actually she could have benefited from the methotrexate. What they didn't tell her in these support groups, but there's an alternative. You can get an IV injection. You can get an injection for it. It takes half a second. It's not that painful. They don't tell us that. So even if some of the drug companies would sponsor a Facebook page or do small TikToks or something, in the patient, but I think it's, for the patient, but I think it's also important that they use a patient as an advocate as well. Somebody to say, hey, I've been on this meds, this is the course of the treatment, hey, it's working for me. And I think that's really important. They don't give, a lot of the social media, a lot of the support groups, they don't give you a positive mindset. They don't give you a positive outlook. My case is a difficult case. I'm on oral and I'm on IV. Plus, I've got a plethora of other diagnoses. Some days I have good days and some days I have bad days, but these are the things that we need to let our patients know. When you have a bad day, it's okay, rest, do rest. Or do like me and call Dr. Bach's office and say, hey, but rest, and then the next day is probably gonna be a better day. But social media, they don't tell us that.
I have another real quick question for Denise and Julie. You talked about sort of the diagnosis is an emotional experience, and many times it's hard for us to remember things we hear. What role does patient education or resources play? And I know we've a long time created different resources, and some are used, some aren't. What are your suggestions as to what would be the best way to, is it written literature, is it video, or what are the key areas that help around that?
Actually, I think both. And you know that in a lot of the exam rooms, you've got the information that's the video information that's constantly scrolling. I find that quite helpful for me. But I like black and white. I like to see it on paper. I do a lot of research, but I still like to have that paper, and I'm highlighting, and I'm just like I'm studying. I think a packet of what your diagnosis, what does RA mean? What is the steps? Because a lot of times, patients don't know. You almost think it's a death sentence. And even for me, who was in healthcare, the first thing I did, I'm looking up, oh, wait a minute, what is my prognosis, and how long, what's going on? But if you have that in black and white at the initial time or close after the diagnosis, you kind of feel better. You can highlight what you need to highlight, go in and talk to your doctor. Because a lot of times we're forgetting to write those questions down. And I think black and white would be really good. Because a lot of times, if you're at home, you're distracted, you're not gonna go to the website and look at a video.
I imagine that is also a benefit of ID, as I'm thinking about it. If I do have those questions, I'm in the office.
Yes.
There's some way. to
Absolutely, absolutely, and that's why I advocate. If a rheumatologist has an infusion suite in their office, I always say, have it done in the office. We talk about my diagnosis and things like that, and we try to figure out why is this happening to me, but I'm almost what you may call a gym rat. So I've been able to, it's just, people have just come out of nowhere that I've been able to talk to. I've referred some to Dr. Bach about different treatments and things like that, and how to advocate for themselves. But I do know, and a lot of them, you know, oh, well, they're sending me here, well, do they have an IV suite? Oh, yeah, they have an IV suite. Okay, well, do it inside of the hospital, the IV suite, the doctor is there. Oh, you don't have a rheumatologist, call my rheumatologist. You don't have a 6-month wait to get in. They're gonna get you in right away. And guess what, if you need that IV infusion, you're right there. They'll ask all the questions. And I think with patient literature as well, on that initial IV treatment or whatever it is, if you can give them patient literature, and Dr. Bach and the PAs are always available, the staff is always available. And in some of the rheumatologist offices, they're like Dr. Bach's office, not as good, but they're like Dr. Bach's office. They're available as well. So if they have that piece of literature, I think it would be easier for them. You know, let me read through this. Oh, I've got a question, let me ask my nurse. And it's also important, and I'll say this, and I say this to patients, and I say it as a patient point of view for your nurse, to know you as well. We had a change of nurses in Dr. Bach's office. It kind of threw me for a loop, even though I know what happens and, you know, those type of things, but I knew that nurse didn't know me. And so the first thing I had to tell her, hey, I'm on adrenal insufficiency, I'm on these steroids. I took this amount this morning. Oh, we're gonna give you no, don't give me 60 milligrams. I'm a hard stick. My old nurse knew exactly where to stick me in. The new nurse, I'm telling her where to stick me. Well, let's try here. No, don't try here. Do it this way. But my doctor is right there, in that suite, that I just say, hey, go ask Briar or go ask Dr. Bach, they'll tell you. But we appreciate the work that you guys are doing as patients, or I appreciate the work that you guys are doing as patients. It really helps us a lot when we know that companies like your company are advocating for us and are wanting to know how we feel as a patient. It's a good thing and a bad thing for me that I come from a healthcare background, but as a patient, we do appreciate what you guys are doing for us, so thank you.
Well, I appreciate you coming here. I just wanna tag onto that to say that, you know, when I listen to you talk about the emotional piece of it, it's a wonderful reminder for me, because I get so focused on, I do this every day, and I forget that too, right? But when you're knee deep in a chronic illness, you need someone to reach their hand out.
Exactly.
And that's what this office does. We reach our hand out and said,
Yeah.
this is every day for us, come with me, I'll help you. And, you know, she's a strong patient advocate. She knows her situation, and I shared with you guys earlier, most of our patients have at least 3 chronic diagnoses. We are not curing disease, we are managing disease. And it is a real emotional, physical issue. So-
And even though we laugh and we're smiling, you know, I greet the staff when I come in, they all know me. Hey, where's Julie? Oh, she's not here today, she's off on Fridays. Or, you know, she's right there, and so you laugh and you joke and you talk. But for patients like me, who spends a lot of time in the gym, I get on that scale, and the first thing I say to Julie is, I cannot lose this weight. Well, I'm on a lot of steroids, it's just not gonna happen. But when you have someone like her or her staff, say, oh, you're good, don't worry about it. You know, just buy new clothes or something like that. Emotionally, I am still in a not so well state. You know, even though I'm smiling, even though I'm laughing, even though I'm getting the support, it is still an emotional toll when you know that I just call it the cocktail. You're gonna get the cocktail, and you know 2 or 3 days later, you're gonna be so tired you can't hold your head up, or you may get flu-like symptoms or something like that. But when you're in your provider's office, and you have people that are reaching out to you, and even with, like I said, literature, I think, you know, it'll be able to take your mind off a little good literature, you know, not literature just saying, oh, this is probably what's gonna happen if you don't get treatment. But hey, you get treatment, look, this is what's, you know, you can live a normal, healthy life. And we don't talk about a lot of the adjustments that we have to make when we have this, rheumatoid arthritis disease, and I think that's something that perhaps, the drug reps can kind of advocate too, is say that, you know, you will have to do adjustments. Like for me, I was probably taking 2 or 3 classes at the gym a day. Some days I can't take it. Some days I can't walk on on the treadmill because my ankles hurt so bad. So I've got to adjust those things. But guess what? It's still a positive because you're getting up and you're going. And I think that we need to, come together collaboratively with the insurance company, with the drug reps, with the provider's office, and talk about these things, and that support group will be able to do that.
And the other thing I wanted to add is, so we've talked about non-medical switches, white bag drugs. When you hear this patient's story, now can you imagine what happens when United Healthcare comes in and says, good news, bad news, we're doing a non-medical switch? The devastation,
Yes.
okay, so that didn't happen in our office, but it only doesn't happen because we won't do it.
Yeah. Yeah, and that's one of the things that happened to me, you know, you can't take this medication. What do you mean you can't take this medication? I have uveitis. This medication is not controlling my uveitis. What do you mean? Oh, well, so you'd rather that I get steroid drops every other month, go see an ophthalmologist who specializes in uveitis, of course we know that his fees are gonna be higher, than to just give me the medication that can control it.
Here's us.
Thank you,
Of course, Claudia, will you help her? Okay, great.
Thank you guys for the opportunity, I really appreciate it.
Thanks for coming out.
Thank you.